So I always say to my patients, um, the same thing over and over again. Keep your healthy parts healthy. They're going to be your best friend when the time comes and you need those best friends. I had a young patient come in to me and athletic, ate great diet. I mean, everything was just perfect. Um, I mean, it was why me. I did everything right. I had my children young. I breastfed. I keep good diet. Why do I have this breast cancer? And I said, well, if you didn't do all of those things, it could have been much worse. All right. That's number one, two, and three. And there's no question that oftentimes, whether it's surgery, with all due respect to our great surgeons, whether it's medications, with all due respect to our oncologists, radiation, sometimes patients walk away with byproducts of those treatments. And there's no question that it runs the gamut. And one of the issues that we have begun to understand is cardiac health issues, that many of the drugs we used 40 years ago and 30 years ago can have a cardiomyopathy associated with it. We have now immunotherapy and in other malignant specialties, CAR T cells, which can have their own issues. And so a specialty called cardio-oncology has been developed. Um, needs to be there for our patients. I try to have all of my patients to see someone who is versed in the drugs that we use. And Dr. Uzzilia, Jeffrey Uzzilia, is a cardio-oncologist based in Albany with Capital Cardiology, who soon is going to have offices at our new NYOH Cancer Center. So we'll just be rolling patients down to you. And not because, yes, that's great. That's great. And the truth of it is, it's not so much waiting for somebody to drop their ejection fraction or to come symptomatic. It's how to be proactive based on what the patient brings in to the room and what the patient's been treated with, to be proactive to avoid developing these issues. So, Jeffrey, I'm going to throw that at you.
Thank you. Is this on still?
Do you want to come up here?
No.
Nobody
No,
wants
I'm
to come
sitting.
near me.
Does that seem to be working? Okay. All right. First of all, thank you for letting us come to your office. We're excited. More excited about that office than the new Casa, which is a little bit further down near Crossgates. So Dr. Heather Staher and I are the two cardio-oncologists in our office that are very interested in this field. We talk, on a regular basis about cases. We talk to her all the time, and we kind of, when we talk about these things, we say it's the best part of our job. It's our favorite clinic. We really enjoy working with the oncologists and working with the patients. But going back to your question, so you know, the classic kind of case that we used to be involved with was anthracyclines, Adriamycin, watching ejection fraction and dealing with the consequences. And now it's become so many different things. As you guys as oncologists have done such a great job in terms of treating patients, and now we have people that are surviving long periods of time and seeing effects of therapies that maybe weren't optimized in the past, higher doses and radiation. So we see all kinds of different effects from the treatments that patients receive. And then I think now there's kind of that second part, and I think Neil alluded to that, is women in general, not just patients with cancer, get underdiagnosed, undertreated with heart disease. So all these patients that walk in, they may have other reasons to have heart disease that have nothing to do with their cancer treatments or their diagnosis. But now we're fortunate. We've got a lot of tools to use. We've got diagnostics where we can look at arteries, valves, lining of the heart. We have therapeutics where we can kind of modify the effects of HER2 new therapies. And there's lots of times where we'll do that very proactively, where somebody's on high blood pressure medication. Like, well, if you're going to be on a blood pressure medicine anyway, why don't we put you on something that protects your heart through this process? So there's lots of things that we can do in a proactive manner, and that as a result of all those things, there's lesser times that we have to say, really worried about this. I think we have to go a different direction, because that's not what we want to do. We want those patients to receive whatever you think is the best for them.
Wonderful. Within the umbrella of cardiac care and within the umbrella of cardio-oncology, it's also all about overall general welfare. Uh, you know, making sure that anything that might be inherent to the patient is picked up early on. And sometimes we're finding diagnoses that we would have never known if they weren't just sent for, being cared for by your group. So I think that's all important. I really do. And I thank you for that. So cardio oncology is going to be at NYOH next door to Costco. And it'll be so easy to get patients to you. So Sandy Sanderson. Okay. Sandra Sanderson is a physical therapist, basically a rehabilitation expert who is probably the most sought after physical therapist in the Capital District. I don't know how you say yes to every single consult that we said. Look at her face. Um, and it's so important because, yes, women do develop lymphedema, and sometimes it's not just in their arms. Sometimes it could be at their mastectomy site or in their breast. And it's not just troubling to the patient because they have this swelling, but it's a reminder that they had breast cancer. They kind of can't get away from that diagnosis if they're having these adverse events. So, at what point in time should you be seeing the patient post op? When symptoms develop, or when there's a centimeter expansion of one arm over the other? Or should you be seeing everybody? You should have an office NYOH too, and just see all the patients in order to be proactive.
Thank you, everybody. It's nice to be here. You're right. Actually, everyone should see a lymphedema therapist either pre-surgery or shortly thereafter, simply for the education alone. A lot of folks will come to me maybe a year later and they'll say, I wish somebody had told me. So I do a lot on education, and some surgeons send folks to me pre-op, mostly because they're like, I know this patient's going to have a complete axillary dissection. We're taking all of the lymph nodes. The cancer's aggressive, so therefore we need to have a lymph therapist on this right away. Get a compression sleeve, educate them on, no blood pressure in the arm, no needle sticks, et cetera, heavy repetitive activities. All of those things are so important to know right out of the gate. True story, 2 months mastectomy and someone's out power washing her house because she thought that she should do that. Now, ended up with axillary cording, which basically you angered your lymphatic system. Now you have cords that go from your armpit all the way maybe down to your thumb. And those folks are 2 times likely to develop a lymphedema than folks that maybe behave themselves. Also, you have to remember years ago, the amount of lymph nodes you had removed basically determined whether you were going to get lymphedema or not.
It was a minimum of 9 or 10.
Right. Now, at the age of 54, my mom had 19 removed plus radiation. She's 87 now. She was not the best patient. She did everything wrong. Heavy lifting, didn't wear a sleeve, I could go on. Luckily, she's escaped a lymphedema. And I say, well, why is that? And then we could have an entire room just like this, lymphedema half and half, would say, well, Mrs. Jones had 3 nodes removed and her arm is huge. And then Mrs. Smith had 19 lymph nodes and never had a lymphedema. Well, why is that? There are a couple of studies out there that show, let's say, speedy lymphatic system versus a sluggish lymphatic system. You would think speedy would be great, that lymph's going through, but take an impairment of 19 nodes. Now you have lymph vessels traveling from the fingertips to the axilla, and they get up there and like, oh, there's 19 nodes gone. Now what do I do? Well, of course, I'm going to make regeneration. That lymph is going to regenerate to find a new node. But in the meantime, if you had a speedy lymphatic system, think about a 4-lane highway, 4 cars barreling down to get on 1-lane bridge. They're not doing very well merging because all that speedy lymphatics is going, and then they're trying to get on a bridge. You're going to develop a lymphedema. You have a sluggish lymphatic system, probably my mom, where their cars are poking along, and then they develop this nice, way of interweaving and getting onto the 1-lane bridge. Fine, they are spared a lymphedema. That's one study. Another study showed that if you already had axillary involvement, in other words, your cancer had spread from your breast into your armpit, you had sprouting, right? Your cancer wanted to go. So you've got lymph angiogenesis. So basically, your lymph has already sprouted. Now comes along a surgeon, they remove the tumor, and they remove the nodes. Cancer's all gone, but sprouts are still there. So that's actually helped you almost avoid some swelling in the arm simply because you had the sprouting. And lastly, basically our anatomical development, right? We know that 2/3 of the population out there have an arm that is basically intact lymphatically. It's called a long bundle arm. So they can inject into cyanide green at the wrist, and they can watch it travel up into the armpit. And there's a perfect lymphatics. There's no disconnect anywhere. Then we have 1/3 of the gals, and all of us lymphatically are, we don't know. We don't know until we come upon this. 1/3 do not have an intact lymphatic system. They were born with disconnect, typically from the elbow up to the armpit. So this could be an understanding why so and so had 3 nodes removed and has a very swollen arm, because maybe she has a disconnect. And then the other folks who have 19 lymph nodes removed developed a lymphedema.
Are you seeing a decrease in lymphedema now with sentinel lymph node biopsies?
Yes, thank you, Jesus.
Good.
Yeah.
And
The
what about lymphatic
surgicals,
transplant? I
yeah,
don't know. Yeah.
yeah. The just differences in surgeries and radiation alone have really lessened the arm lymphedema, but we do see a lot of breast lymphedema now, more than ever. I've been doing this for 25 years, and the breast lymphedema has exploded, the truncal everywhere. So we're addressing that more with manual work and also garments. You see a lot more compression garments.
I am a big believer that there is a need for more resources, more of you, more of a wider clinic supporting you, or even grant, perhaps a federal grant, so everyone who has surgery has to come by your clinic pre-op and post-op. I really do believe it.
It would be
It's
wonderful.
just a chronic reminder. With that, I'm going to jump down to the end to Francis Ford. And Fran, I don't know what I would do without you at NYOH. Francis is she goes under the title of social worker, but she's not just social worker. She is the one who understands the psyche, the heart of patients. She knows what it's like to have a 7-year-old child whose mother is going through end stage disease, and not only to deal with the family watching the patient, not only to deal with the patient, but how to deal with a 7-year-old child, which often can be devastating. Um, Individual therapy, group therapy, telehealth therapies. How do we divorce in a patient who is without evidence of disease? What I see, thankfully, in a small number of patients, the diagnosis, just having the diagnosis, causing such fear and anxiety, even in an NED status, patients are living as if they're stage 4 when they're not. What tools, what do we have, please?
Sure. Thank you so much for having me. You hear me? Um, so again, thank you for having me. I mean, I think the first thing I always like to say is that I say most patients are all feelings are natural. I think that so often there's an expectation, I have no evidence of disease. I'm supposed to feel positive. I'm supposed to feel happy. I'm not supposed to feel anxious. And so I think the first thing I always like to talk about is to think about all our feelings as natural and expected. When we go through treatment, we expect maybe nausea, we expect a lot of physical symptoms, and maybe we don't talk enough about there's also expectation that we're going to have a lot of emotional symptoms. And so I think the first place to start always is to name that. And to realize the feelings of sadness or anxiety or fear are just as natural as feelings of gratitude and positivity. I think also often my referrals don't always come when someone's first diagnosed. That happens, but often my referrals come when treatment is over, when someone is settled into treatment, years after treatment's over. And I think that's often because it takes time for our emotions to catch up to diagnosis. So oftentimes there's almost the safety in treatment. There's a safety in going to treatment every week. There's a safety in scans because I'm doing something. And when there's nothing more to do, that's often when we sort of sit back and say, oh my gosh, what just happened? And so that's often when I come into play too. And so then what do you do? And so my goal is always to try to figure out what is a way that we can get the support that you need. And support can look like so many different things depending on who you are. So for some people, it's individual counseling. It can be really helpful to have a space away from our family, away from our friends who we often are trying to protect. I'm fine. Okay. Everything's going to be fine. And I have someone separate to talk to. Sometimes that support can look like a support group. What I really need is to talk to other people who are going through this. And that's where I'm also going to just sort of make plug that can also be true for loved ones and caregivers. I need a place to talk about what it is to care for someone that's going through a cancer diagnosis. Sometimes I don't need a therapist, but I want a one-on-one mentor, someone who is a little farther along in the journey than me. How did you cope with that? How did you deal with that? So my goal always is to one, really acknowledge and normalize the feeling. And so I'm here to really say whatever it is that you're feeling is okay. We might not talk about that feeling, but it's natural, it's expected. Someone else out there is feeling it too. And then what kind of support do you need to feel better, to feel heard? Emily mentioned the writing workshops. Some people don't want a support group where we're talking sort of just about feelings that might not feel right to you, but have an opportunity to write about what's going on in your life, write about your cancer experience in the context of other people that have been through it can be really helpful. So in my mind, asking for support is the number one thing to do, and then working with the social worker or therapist to figure out, and what does that support need to look like for you? So
There's not enough of you. I will say this out loud. We are very poor and in need of mental health resources overall. And I don't think it's just up here, I think everywhere. Um, Certainly in the oncologic arena, where just the word alone can paralyze someone. And even with stage 4 disease, advanced disease, I viewing it and the way one lives their life and continuing to exercise and be social, as Dr. Iyengar was saying, even within that arena, it's so important for overall survival. Um, there's just not enough of you. So I think Sandy and you should go off in the corner and figure out how to clone yourselves. Or everyone in the audience demand that we hire and do better and recruit people. That's what we need for all of us. Tiffany, Dr. Troso-Sandoval spent a couple of decades at MSACC, medical oncology. And did you just breast?
Breast and GYN.
Breast and GYN. Okay, you're going to say on this platform. Um, you recently wrote a book, and it's coming out for publication September 1. And so,
It's like a 3-year-old baby coming out at this point.
oh boy, oh boy, and I have to say, when Donna was up here, and talking about how she wrote her music allowed her to get away from her disease and function within some normalcy, maybe diffuse the chaos and the scatter and the fear. Do I have to say any more? Do you just want to continue what I'm talking about?
So my book is called Calming the Cancer Chaos, and it's a book that lived inside of me for 25 years building, and it was grown out of learning from my patients, not just what medications they need or what the chemotherapy was. I always used to say medicine's almost easy. Everything else is somewhat what's harder. And so this book is intended for patients that have developed cancer. It's primarily focused on women to help them understand the cancer, the whole journey. What is a pathology report? How do I read it? What are the different radiology studies that I might come across? Different surgeries? Who are the other specialists that might be available to me that could really help enrich my experience? And I also spend a lot of time explaining how important it is to not just understand the words, but to also feel the confidence that you are the most important person in the room. And that as a patient, it's very important to empower yourself to get the best outcome that you can, not to be a passive patient. I often use the phrase become the CEO of your cancer care, your cancer executive officer. You're in charge. And so if you don't understand something, you need to ask. If you don't get along with your oncologist or they're not explaining something or whatever, you don't like the color of their hair, I've heard that, um, maybe you need a second opinion. Either way, at any rate, I could go on and on. It is 250 pages. The point of the matter is that I think it's really, really important for women, especially, to take their place in the exam room and realize that they need to put themselves first, maybe for the first time in their lives, and make sure that they're getting the care that serves them best. Because I've found over the years that not every single patient has the same outcome in mind. A patient who wants to go to Florida for the whole winter with her husband because that's where they thrive, well, maybe she's not the one that needs the weekly chemotherapy that only can come from my office. Maybe we're going to work with another oncologist in Florida and coordinate that care. Maybe the patient who has young children and nobody to help care for them, she needs additional support so that she can actually get to her treatment. So there are so many things that I've learned about from my patients behind the scenes that are more than just specific medicine themselves. But part of my book, the purpose is to educate you on the parts of the oncology medicine so that at least we have the vocabulary to understand and to communicate with caregivers, our loved ones, as well as all of our family and friends who want to help us.
Can you talk about the workbook that accompanies the book that you wrote?
Oh, thank you so
Well,
much, Maria.
very, very important.
Thank
Very,
you. First, I also have to mention that Maria was an
and it comes
extremely,
free with book.
Dr. Theodoulou was an extremely important part of this journey. I thought I had finished my book.
I read the first draft and I told her I didn't like it. How
She
do you
ca-
like that?
My husband was sitting in the room. I put the phone on mute. I go, oh shit. Oh, I didn't just say that. Anyway, but she added so much value to what I was saying. She let me step back and really read the words as a patient. And although I knew I was writing to patients, I think you really helped me find my voice. So thank you. Okay, so the book is being published on September 1st, and it does come with a 145-page workbook that I created that is free PDF download that actually enables you to not just understand what you're reading, but actually put it into action. So I have pretty much everything I could think of that a patient would possibly face through their journey and how to document it and how to create a journal and how to make a binder to organize all of your things. And the foundation has very generously offered to pay for some of the books or all the books. If anybody is interested in purchasing it, you need to pre-order today, and that's the QR code. And so I would be
We will
absolutely honored.
support it.
Thank you so much, Maria. I appreciate it. And I really hope that if anyone gets a chance to read it, that you find it helpful. And it's my heart and soul. I feel like it's almost a culmination of my career, though it's not. 'Cause I'm only 57.
Congratulations. I'm very proud of you.
Thank you.
You know, the issue is I've been asked multiple times throughout my career to read something, prove something, give advice, and I'm not a yes person. And so sometimes I say, no, no, no. I will say when I reread it, I was so very proud of you. I would give it to all of my patients. But you said something. Women often don't put themselves first. And that is my segue, Jeanne Carter, because we are caregivers, we are career women, we are warriors, we are doing everything all the time. And oftentimes we don't pay attention to one of the things that makes us comfortably whole. And Dr. Jeanne Carter is the chief of sexual health at Memorial Sloan Kettering Cancer Center. I worked with her when I was at MSKCC for years and years. I continue to work with her since I left. Um, it is such an unmet need because women don't talk about it. And we have to find a way to create that voice because it's not just about penetration, it's about our overall health, how we pee, how we feel, if we're comfortable. I'm going to stop talking. Jeanne, it's all yours.
That's a great
And I have
transition.
multiple questions here, so get
Oh,
ready.
wonderful, wonderful. No, I think a lot of what's been said today is really nested in what I do. I think I always tell my patients, cancer's taken enough, we're not going to let it take more. And the key to this is to find it's going to be a bumper sticker one day. Cancer's taken enough, we're not going to let it take more, right? And I think it's the key for all of this is there are so many changes that happen so fast and it's daunting emotionally, physically, spiritually, and you're trying to take care of yourself, but it feels like a full-time job. And then taking care of yourself from a women's health standpoint feels like something that maybe is a luxury you don't have time for, you worry about costs, but it is so important for you to find a way to help your body to heal and find balance. And, a lot of medications that are wonderful and helping our patients live longer can have very dramatic um, results on vulvovaginal health, which, you had just hinted at, going to the bathroom. That's true too. I mean, you can't not use this area. So women are having painful exams, risk for UTIs, discomfort with daily activities, working out, and just don't know that there are simple solutions. That does then translate into intimacy and comfortable exams. So I think we just do a disservice in our society of not teaching women how to age gracefully. Estrogen is natural moisturizer. So when you don't have that, either you have to put it back, which is a big source of conversation and controversy, but you can put things that are hydrating, that are non hormonal, that are over the counter, that are very simple, that are being marketed out there for just general menopause. But if you do that without guidance, you will not get symptom relief because what women go through is not a natural transition. It is usually quite a drop off. So we have studied products that are hydrating, that have hyaluronic acid, which is in every facial cream. I know people are using it on their face. You can literally use this in your vagina and apply it also on the vulva, which maybe people talk about the vagina, nobody talks about the vulva, but the vulva is important for women. From a sexuality standpoint, the clitoris is external. So if you're not moisturizing that, it can have changes in tissue quality, sensation, comfort. And then there's also the opening of our vagina, which we call the vestibule, which is where women usually have burning discomfort after exams or sexual activity because the tissues are so fragile when they're thin. So these products can be used both internally and externally, but at a higher frequency. We know from studies that it needs to be 3 to 5 times per week. We do it at bedtime, so gravity works with you, not against you. I call it my skincare everywhere to try to get women to pair this with their routines at night. So it doesn't feel like another chore. It doesn't feel like another task because I do understand there's a lot of things you're doing, including massage, for lymphatic drainage. And these are things that if you can incorporate in, just will have a huge impact just on your life and your comfort. And a moisturizer is not a lubricant. And I know a lot of people know that, but in case you don't, a lubricant is something that's there to supplement your natural lubrication. That's why you get With an exam, doctors put a lubricant on. If you're going to have sexual activity, as we age, our lubrication response is not as robust. That's why we have all these wonderful products, but they're temporary, they're a band-aid, and they're not moisturizing. So if you're going to put time, money, and energy into healing your body, it serves you well to use something that is hydrating, both internally and externally. And if that's not working, then there are options sometimes for low dose vaginal estrogens for women who have chronic UTIs or tearing or discomfort. And we have done studies at Memorial looking at estrogen levels. Low dose vaginal estrogens are available in a low enough prescription that it's not causing any elevated sustained peaks, which is what all medical oncologists worry about. So there are great conversations that you can have with your providers if this is an issue for you, but definitely I would say start with the over-the-counter, non-hormonal, do not require prescription healthcare products that are used on the face that can be used in the genital area. It just can make a huge issue in your overall quality of life and comfort.
Jean, you're under GYN service at a major tertiary cancer center, and I'm imagining that you're getting a lot of your referrals from the GYN physicians. But what about the general population who's seeing their primary care physician or who's seeing their medical oncologist? Eh, How does the conversation happen? I know in my clinic with my nurse practitioner, it is part of our routine. It is part of our review of systems. We bring it up, we talk about it. Um, it takes time. It takes time, but how do we educate our patients to feel more comfortable about that conversation, that it shouldn't be something hidden in a closet?
Well, I had a question one time from a radiation oncology resident who said the same thing. How do I bring this up? And I said to him, well, do you screen for menopause? And he said, yes. And I said, well, that's where the conversation should start. So if you're not comfortable talking with your provider about sexuality, which not everyone is, women's health is something we should all be talking about. So you can say, I'm having some changes in the tissue quality. I'm having some discomfort with daily activities. Or I had someone say to me, like, I got on a bike and it was really painful. Or I wore my favorite pair of jeans and now it feels like sandpaper. Like you can just bring up that there are changes that are going on that you're not understanding. There are so many great information, patient education, services out there. I mean, you can Google it online and information comes up. So don't not have the conversation if you're not comfortable talking about sexuality. Start from the standpoint of it was uncomfortable to have an exam. It was uncomfortable maybe have sexual activity. That's also very important to discuss, but I want to come from where you feel comfortable. We should all be advocating to have comfortable sexual activity and conversations and make that forum not feel so daunting because people say to me all the time, is it just me? Am I the only one? And then I'm like, well, we have a program. No, you're not. But I do think it's important to at least feel like you can bring this up. It's on our job as the providers to make that safe space. And I was talking to someone the other day who was saying like conversations aren't happening. I'm always thinking about like at Memorial, like we move in packs. Sometimes in packs, it's not easy to have the conversation. So you could ask your provider, is there a way that you could, just talk to them for a moment or grab the nurse or if you're with a family member, just ask for a moment when you ask them to go get you a cup of coffee or water. Like the environment is so important for these conversations to happen. We need to have more screening tools so that we're identifying that so that we also can initiate that conversation. But I think it's important to advocate for yourself 100%. Like you've worked this hard to be here. You deserve to have quality and comfort and joy.
It's not age specific. My younger patients bring it up all the time, but
You have 80-year-olds. Don't say just young. I have 8-year-olds in
no,
my
that's what
clinic
I'm
too.
getting to. We can't discount our 70s and our 80s.
Yes.
About 25 years ago, I had a 79-year-old female on an aromatase inhibitor, and she was coming in for routine follow-up. It was 3 months. after I started her because I wanted to keep an eye on how she was tolerating it. She came so angry at me, angry, and I, I was, paralyzed. And it doesn't. I mean, I talk. I couldn't even speak, and I tried to call her. And I said, "Why are you so angry at me?" She said, "Because my husband's angry at me." I said, "I don't understand." She said, "It hurts now when he wants to have sex, so I don't have sex." He's blaming it on the medications. 79 years old, and she just wanted to have a robust, healthy sexual life. We started the conversation. We had the conversation. I had her see someone in your department. I think maybe it was you. I don't know. Came back on her next visit very happy. So was her husband.
Can I just
Um,
can I just say one
so
thing about the
question. Oh,
older
yes.
about the older population? Incontinence is a very common thing as we age, but I have found that it can have a huge negative impact on vulvovaginal health. Women are wearing pads and panty liners. You see all these commercials now for the pretty pull-ups and everything, but they do have an impact that if you need to wear a panty liner or a pad, wearing a barrier cream is so important. Otherwise, the tissues just
Yes.
dry out. Women like scratching themselves, so we call excoriation, and just it's terribly painful. And we learned about the barrier creams actually from our colorectal and anal cancer patients post radiation. They're having a lot of GI issues, and these creams were truly their lifesaver. So,
I'm
you
so
know,
glad you brought this up.
yeah, try to avoid panty liner and pads if you can, because they really do their job, which is to wick away moisture, and the plastic adhesive smothers everything. If you have an incontinence issue, you must look into barrier creams to protect those tissues.
So I have one question, and Fran will take away my mental health if I don't ask it. Um, what are the current FDA approved treatments for lack of libido and vaginal atrophy on patients on hormonal therapy?
So FDA
Should I order dinner?
no, I'm not going to dominate this. Just a few things. So FDA approved medications for hypoactive desire disorder are bremelanotide or Vyleesi, which is a sub-Q injection. It's non-hormonal. That's what I want you to remember. All the medications that are now coming out for desire are non-hormonal. They're working on the dopamine, serotonin pathway, working on brain chemistry. The other one is fluancerin or Addy, which is now marketed as the pink pill. I mean, I guess to go against the blue pill. It's definitely inspiring to see that the pharmaceutical companies are now taking the time to look at this in female sexual medicine, because there's been such a heavy focus on male sexual function. But I do think there's not a panacea for improvement in these domains. We did a study, a national cooperative group trial with breast and GYN cancer patients, and we offered them Wellbutrin or bupropion, which is given to women who are on serotonin reuptake inhibitors like Zoloft, Paxil, because they can have sexually induced dysfunction. So we took all comers, and when they were writing the study, I said, please, you have to have them use strategies for vulvovaginal health. And they said, oh, we'll just if they want to use them, we'll let them use them. I said, no, 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 you need to have them use them. They said, no, we'll just let everyone use them. Okay. So the study comes out negative. Not a surprise, even though clinically we've seen this medication be helpful. So we went back and we did an ancillary data review. And in the population of people, whether they were getting the bupropion, different doses, or placebo, in all groups, the strongest predictor for having low desire was lack of lubrication and pain.
Hmm.
So I always say, like, you want to improve desire, you have to take care of the basics. You have to make sure that women are having comfort, that they're not having pain, because it's hard to experience pleasure or to have interest if you're doing something that's not comfortable.
Or want to go through again?
Right. So that's desire. For vulvovaginal health, we mentioned this before. Like, there are wonderful strategies that are available over the counter that people can be using. The North American Menopause Society always says start there and work your way up. Low dose vaginal estrogens would be the next escalation. Sorry, tongue tied. I need more coffee. And now there's all this debate about HRT. And what we usually say is that we don't have the data to guide us. Like, are doing some studies in Europe, and hopefully we will have the answer for that. But the pendulum has swung. First, it was everyone was on HRT, then everyone was not on HRT. Now everyone's going back to that. when people tell me that they're having an issue with sexual functioning, I'm always saying, what are you treating? If it's desire, we have non-hormonals. If it's vulvovaginal, we have non-hormonals. If it's arousal issues, that's circulation. So that's really trying to work with devices. I mean, pelvic floor exercises and Kegels works the same pathway for your arousal response. But there are studies that have looked at vacuum devices because whatever they use on men, they use on women, and use vacuum devices to help them with erections. And that has shown to have some positive data. Vibrators has also been shown. So there are things that you can do that are within the realm of being non-hormonal and optional for you. And then you escalate as you need. And that's an intimate conversation with you and your provider based on your disease, your characteristics, risk, benefit risk, because there's a lot of conversation now about what if you're triple negative, like why can't you do that? So that has to be a thoughtful discussion, but you really need to understand what are you treating, how are you going to treat it, and escalate the things that are not harmful to you and take the risk in increments based on what your need is. Is that have I answered your question?
Do you have a podcast?
No. And I don't write either.
Didn't she have a podcast? Yes. So thank you, Jean. That was great. We have a question, and I saved it for almost last because we're going to address bone health, and then we're going to finish up with some comments from Dr. Muss. Um, you'll hear about them, and a short 3-minute video, and we'll close. But I want to introduce Dr. Azeez Farooki. There he is. And you can come up here. You always tower over me. Do it again. Uh, and hi. So Dr. Farooki just came from Santa Fe, the Bone Health Conference, and thank you for coming up here. He is an attending physician of endocrinology at MSKCC, an associate clinical professor at Weill Cornell. His research, his whole focus is bone health, and I will say to you that I'm thrilled that you're here. I have a question that we can kick off with, but while I was scanning the audience, I found Dr. Robert Bush. And did you ever run across each other? He trained at MSKCC, endocrine up here in Albany, who deals with bone health. And I said, why not abuse Dr. Bush? He didn't know he was going to be up here, so we pulled him up here, and they'll keep each other sober. And let me ask you a question, then I'm going to move away from here. Will anyone be speaking on osteoporosis after the use of aromatase inhibitors, or maybe while on the use of aromatase inhibitors? What do you recommend when we should start these medications? Or do we have to wait until after all of our cancer treatment is completed in the adjuvant setting before we address our bone health? I'm actually going to go sit down.
Please.
Go for it.
Yeah, thanks, Maria. This is a great conference. I've been here before, and just an honor to be here. Yeah, like Maria said, I'm the bone guy. Once they realize the patient has a skeleton, they say, well, send them to Farooki. So anyway, to answer the question, no, you don't have to wait till all your therapies are over. In fact, there's some really, I think, underutilized, expressed information that I want to get across here is that some of these bone protective medicines are bisphosphonates, particularly, have two benefits in postmenopausal women with breast cancer who are on medicines that can make their bone density get worse and increase their risk of fractures. So these two benefits, one of them, well, they're bone protective medicines, and they're going to protect your bone density and they're going to lower your risk of fractures. But the other one, if you're a postmenopausal woman with breast cancer, it doesn't matter if you're estrogen positive or negative, there's good evidence that they reduce the risk of those cancer cells coming back into the bone. So you can think of it as the bone is the soil, and the cancer cell is the seed. And these medicines, they make the bone, the soil inhospitable for the seed to recur there. So, if it's my family member, I literally tell patients that, yeah, I mean, I think this is very important information that you get these two benefits from taking this one bone protective drug that's not chemotherapy agent. It's an FDA approved drug to reduce the risk of fractures. And the one that really has the most data behind it is zoledronic acid, is the generic name. It's an IV medicine. And now, all that being said, these drugs have a lot of baggage, and that, well, this, side effects that, what about these side effects? And we can get into all that. So the answer to the question, however, is that no, we try to block the bone loss. See, if we do nothing, in a lot of patients, their bone density will tank. And even if they're young, we don't worry about them breaking bones when they're young as much as when you're older, but we kind of want to think ahead. You don't want to let your bones disintegrate and when you get in the soup when you're older.
Here we go. Can you speak a little bit about rate of bone loss? You know, I can certainly order bone mineral density, and I can see if it's normal or assess whether there's been a change. It's there in black and white.
Mhm,
I'm reading the report,
mhm, mhm.
but I'm not capable of evaluating the rate of bone loss or whether an intervention has to be put forward or whether there's some other process going on with the parathyroids or whatever. I can certainly draw the labs, but putting the whole story together, I think, is important. And are there patients who have osteopenia or even near osteoporosis who may not need medications because they're very slow losers of bone and they're leading healthy lifestyles? Can
Yeah,
you address some of that?
yeah, no, it's a great question. We all, tend to lose some bone as we get older, and that's with every year 0.5 to 1% bone loss per year. And when you go through menopause, there's an accelerated rate of bone loss for 5 to 8 years. Um, so that's just the way it works normally. When you get put on, estrogen blocking medicines such as aromatase inhibitors, um, in distinction to tamoxifen, by the way, in postmenopausal women, tamoxifen acts weakly like estrogen on bone, so it's kind of good for your bone. But the aromatase inhibitors rev up that bone loss. They accelerate bone loss. Um, so therefore, they also increase fracture risk and so forth. And I think the point is when you look at these bone density reports, what I tell patients is that you got to look at sometimes like the stock market and look at the big picture, look at multiple time points to see where the market is going, right? Because you can get fooled in the short term because there's an error margin to the test. And it says it on there that, and most centers will calculate what's considered a statistically significant change in terms of the percent from one year to next year. So if you have a 0.1% change, that's non-significant, right? But if you have a 5% change, that's outside the error margin of measurement, which, let's say it's 2.5, 3%. So sometimes we look at it and see where things are going. Other point I would add is that, you can do a bone density after 1 year if you're concerned. And to answer the point that was brought up, that Dr. Theodoulou mentioned, is that what if you start out with really good bone density? And yeah, I think that's if you can just wait and see, you can see, well, what happened after a year. Did I lose a lot? There are situations where premenopausal women are put on ovarian suppression medicines who have breast cancer, and their bone density can go down quite rapidly, and it's alarming to some patients like that. But that decision, kind of relates to this concept of if you're a minimalist, your philosophy, or you're a maximalist, which means like some people are like, doc, you keep drugs. I don't want it. I've done enough. Like, I don't want any more drugs. They're minimalists, and that's fine. But other people are like, yeah, give me everything you got. Give me more. So that's how, when somebody asks me, like, well, what would you do if it was your sister? I think that's a fair question because my sister does have breast cancer now, but I can answer it from my own personal philosophy. I tend to be more of a maximalist with the bone drugs because I know that they're going to be safe, so um, yeah. Did I cover everything in there? Yeah.
Yeah, and I guess a question I have, you're in a tertiary institution. Uh, Bob, you're in the community. Although you function like an academic institution within your own office, um, where are your referrals coming from? Are they coming from primary care physicians? Are they coming from their gynecologists? Certainly, we in the medical oncology field abuse endocrine. Virtually everyone is sent to endocrine. Um, where are your referrals coming from? And are you ever surprised to find out that you're seeing someone who just sustained a fracture and has not had baseline bone density? And how do you address that in the community, Bob? And what do you see in the tertiary centers? Oh, it's not.
Oncologists use steroids a lot, not so much for breast cancer, but if a patient's on steroids, that can cause fractures. And patients on steroids prophylactically go on medications to prevent bone disease. For the relatives of people with breast cancer, for postmenopausal women, give viloxazine if a patient, not only does it, if you're osteopenic, prevents the osteopenia from getting worse, but it also may prevent estrogen receptor positive breast cancer because it blocks estrogen at the breast. So that's something we use favorably as well. And just to bridge back to the physician who left with the GLP discussion, don't take compounded GLPs. You don't know what you're getting. These are not FDA approved. I've heard of people who said, I want to get retatrutide, triple G, 28% weight loss. It's not even on the market, yet people are getting compounded Retta, particularly in New York City.
Where are they getting it from?
Well,
Online.
online. They could get it online because of the dramatic weight loss. You don't even know what's in there. The compounded therapies have other junk in there, and they've been studied leading to deaths as well. And it's very common for entrepreneurial clinicians to be selling these medications because the weight loss is sexy, and that's not something you should have done. There are a bunch of other GLPs that will be coming out in the future that are monthly GLPs, a bunch of different oral GLPs that are being ethically tested now. But don't fear, that wasn't discussed because of the breast cancer potential benefit. But GLPs, cardiology uses most as well. They lower heart attack, stroke, and death. They lower fatty liver going on to cirrhosis, called MASH. You see a lot of TV commercials about MASH with other drugs that benefit that. They treat fatty liver, they treat obstructive sleep apnea. So there are a lot of other benefits. So I know you asked, should everyone be on a GLP? If you're an endocrinologist, everyone is on a GLP because they're
I think
overweight
I
or have
think the three
diabetes.
initials, F like in Frank, D like in dog, A like in apple, FDA. If it's not FDA approved, don't. Just don't.
And most GLPs are compounded GLPs that people are getting because unfortunately for obesity, GLPs aren't off covered, except if you're 65 and over and on Medicare. GLPs now are covered. They're called a bridge program. They're $50 to get a GLP, ethically prescribed if your body mass is above 27 and higher. I would not give it to the BMI of 23 that you talked about.
Thank you. Azeez, I have patients on tamoxifen. They complete 5 years. Some of them are on even longer. And I know that when they stop the tamoxifen, they're going to have a dip in their bone density, on the following evaluation. Do we ever take that into consideration for prophylaxis?
Yes, and tamoxifen, like we were saying, is bone protective if you're a postmenopausal woman, not so if you're premenopausal. But yeah, if you have, low bone density, osteoporosis, near osteoporosis, if you have osteopenia and have had fractures, that would be somebody, if you're stopping tamoxifen, we want to give something to block the bone loss because it's like taking away the estrogen. So I would give some bisphosphonate probably to that patient.
Well, everybody will be available for a few minutes. If you have any questions, let's give a great round of applause to everyone. Dr. Muss and I were speaking earlier, and because his specialty has been geriatrics, which we're changing the name of, and because of we're changing the name of it, and because there are so many issues by way of patients living longer now, getting to the point where they're considered geriatric successfully. There's so many other issues that we need to address and think about. And please take a few minutes and talk about what we spoke about earlier.
Yeah, so can you
So
hear
much for
me?
letting me put you on this.
Well, first of all, what a great conference. And Oprah has a replacement, I think. Um, so it's true. So Dr. Arena mentioned Christina today. So this was his neighbor that died of leukemia. And one of the miracles of oncology now is that most children who have leukemia and young adults are cured. So about 80 to 90% are now cured. And that's great. But what we forget, by the time these kids are 35 and young adults, about 20% of them have passed away of other illnesses. And some are second cancers. If you have one cancer, you're always at higher risk to get another one. And some of them are disease of aging. They're heart disease, diabetes, other problems related to aging. And so what we've learned from the children is that a lot of the drugs we use, as good as they are, they can have adverse events that occur very late after treatment. And one of the miracles of breast cancer now is most women with breast cancer now are surviving it. So in the United States today, the vast majority of women who get breast cancer are surviving it. And, we all love our oncologists, and you're 5, 10 years out, and you still may be seeing mental health about fear of recurrence, but you're really going on with your life. And you're not worrying about your breast cancer. But what we've learned is our drugs can precipitate things like heart disease, we've heard. Some women have nerve damage from a lot of our drugs and walk around with numbness and tingling. And then there are things we haven't talked about today, like chemo brain, right? We talk about it. Women told me about it all the time. What is it? And it's a very real thing. It's very hard to measure, and it's real. So the research I've been interested in, and bless you, Breast Cancer Research Foundation, has been, can we look at women who have been treated for breast cancer and define those women who are at greatest risk for side effects down the road? And those side effects can be heart disease. We don't want to wait till they show up in the emergency room in heart failure. We want to know right after their treatment, is their heart damaged? And all the tests like echo tests and other things frequently don't show anything. Now we're getting better tests, MRI tests that do it, but we're interested in finding those women who have been treated who might be at greatest risk down the line for serious problems, heart disease, lung disease. We're talking about all these hormone therapies and depleting women of estrogen, and there are worries. Does that accelerate cognitive loss as they get older, the lack of estrogen? Things we're really interested in. So I've been fortunate to receive grants from BCRF and others to look at your bloodstream, measure your blood, and measure how old you are biologically. So you may be 50 chronologically, but you may be 60 or 70 biologically. And we measure that by looking at different chemicals in your cells, and we can be pretty accurate. Now, in an individual, if I measure your blood now and I see you're biologically older, I can't tell you how long you have to live. But I might be able to think of preventive measures on the possibility that that's true to make your life better. And it can be lifestyle changes, right? Exercising, losing weight, GLPs, whatever. So that's been an interest. But right now, we're moving into being able to measure in your blood. You've heard all about the circulating DNA. We can measure little proteins in your blood, little chemicals in your blood, and we can now begin to tell how old your individual organs are. So I can treat Mary Jones with adriamycin, and some of you may have had it called doxorubicin. Patients call it the red devil. Um, and we can tell every woman who gets that drug is going to have a little bit of heart damage. But fortunately, most of the women don't get enough of it to cause heart failure. But these ejection fractions, how strong your heart pumps that are taken after treatment, they're very inaccurate. They may look great. But 10 years down the road, someone may come in with serious heart disease. So we're trying to tell right after your treatment, you have a normal ejection fraction, you can walk 6 blocks. How old is your heart? And we can compare these chemicals with people who haven't had chemotherapy. So we can get an idea of who may be at greatest risk. And it's going to be years later of heart disease, nerve damage, perhaps early cognitive loss. We can do this down the road. So why do we want to know if we can't do anything about it? Well, we can do things about it. We can get you to a cardio-oncologist. We can get you exercising. We can get you to lose weight. We can make sure you've got maximal blood pressure control. We can make sure your cholesterol and all these things that are not hard to do are taken care of. And then we're hoping to be able then, if we can identify these higher risk patients, to also look at interventions like things like statins or other chemicals that may be helpful. And then the last thing I want to mention is we're looking at during chemotherapy. We know that a lot of women report chemo pain after chemotherapy, and they tell you they're confused and fuzzy. Most women get better, quality of life improves, but we're trying now to test chemicals, drugs that are available, memantine, for things like mild Alzheimer's during chemo to prevent this. And so we're measuring women's cognitive function and then treating them during treatment, randomized trials to see if we can help them. And we're also looking at new drugs now in patients who have had chemotherapy. You know, it's $1 billion business in keeping everybody young and giving everybody blood from 15-year-old kids out of, the billionaires who want to live forever. We're actually looking in a setting in women with breast cancer who have had chemotherapy. And after the first year, those women who can't walk about a quarter of a mile in 6 minutes, we're putting them on a study where we're looking at really grueling exercise regimens with coaching and an antioxidant drug called Ficodin. And you can buy that on the web, but don't, because you're not sure what you're getting. And we're seeing if we can strengthen these women. And we're also looking at everything in their blood, like circulating DNA and their age of their organs, et cetera. So there's lots of exciting things. And we're interested in this because the vast majority of you who have had breast cancer are going to do well. And even the women with metastatic disease, many are living for years and years and doing well. So to me, this is where we're focusing now. And we hope we're going to be able to have women have long and high quality lives through this research.
I can't thank the faculty that made their journey, some from Houston, some from San Antonio, from Atlanta, North Carolina, Albany, New York City. What a treat today. I'd like to, before my closing mark, show you one video. Oh, that's me. That's me. Okay. This is one of my patients. I met her quite some time ago. Probably, I don't remember exactly, maybe about 7 years ago. She came to me with a high risk cancer, multiple lymph nodes. Her metabolism was such that she had very, very difficult times with her systemic therapy, whether it was chemotherapy or endocrine therapy or cell cycle inhibitors, often not being able to complete the treatment because of toxicity. Unfortunately, her disease did progress and she developed peritoneal metastases from her cancer. And her dream had always been to live in a home that she and her husband were building in, I'm not going to name the place, but it's the middle of nowhere, Alaska, truly in the middle of nowhere. You would have to get a plane to go to Juneau or Seattle, but breathtakingly beautiful. A National Geographic photographer who really, it was important, her quality of life, and made a decision because of intolerance treatments that she would no longer be treated. And she went to their new home and made a decision to move forward with hospice. But there was not really a hospice there. And there was no way for her to get medication when the time came to keep her comfortable. And decided to come back to me to discuss end of life, to discuss comfort care. And I said to her, look, let me just do one thing. Let me just draw a blood test, which looks for circulating cells, and see if we could identify any triggers or any new mutations in the cancer that has evolved today. Because we know that breast cancer, when it's found in the breast, oftentimes can change its face, change its profile, as it finds different places to make a home in. And I did send off that blood test, and I found out that she had a somatic mutation in ERB2. Now, and her, she was not approved for somatic mutation. I may lose my license after this, but I presented it. I got insurance authorization, treated her. She had a hell of a bad time with side effects. Finally, got her on core dosing, and her markers dropped. She felt better. And after 5 cycles of treatment, made arrangements for a medical oncologist that was a bit of a plane ride away from her home in Alaska to continue her treatment. And they moved to Alaska. And I received this 2 weeks ago. Both Kim and her husband were celebrating their 20th anniversary. And she said she was sending this as a love letter to me. And I said, may I share this with my audience at the survivorship symposium, veteran symposium, and she said yes. So,
hi, my name is Kim Clune, and I've been a patient of Dr. Maria Theodoulou's for 7 years now. When I was first diagnosed with cancer, I had just come to Alaska, and I was offered a job that would take me around the world as a wildlife photography guide and photo expedition leader. And then I was diagnosed and lost everything. There were dark days, and there were times I thought I would give up. I had been through rigorous treatment that was so hard on my body, more so than most people, that I was ready to quit. We knew life was short, and so my husband and I raided our retirement fund and we built this house. About halfway through the process, we found out my cancer was back. When we drove from Alaska to New York last September, we thought it was from hospice care. I was given one more chance. I have reached my 56th birthday, which I didn't expect to happen.
I'm making big, big wishes this year.
I've been able to enjoy my 20-year wedding anniversary with my husband, the love of my life. When we made our hospice journey, we drove through beautiful places where we would dance because we thought they were going to be our last dances. And this year, we came back and danced with Hope at the side of the river in Jasper with no music, just the current. And it was just magnificent. These lupins behind me, I planted them 2 years ago. It takes 2 years for a perennial to bloom, and I never thought I'd see the day. But I'm sitting here in my garden surrounded by them. But they did give me one little November surprise in their first year. It grew! I can't believe it came back to my lupins. Oh my God. Whatever you decide, whether you take the chance or you don't, there's no right answer. But taking the chance was the right one for me. I just want to say that when you think no hope is possible, sometimes it's the only thing there is.
I want to thank everybody who helped organize this. It was a short notice to get this program to all of you. I hope you all walk away feeling that you learned something today that you didn't know before, or feel inspired by someone's story or someone's music or someone's book. I'm grateful for all of you that are here on a beautiful Saturday. And there is a survey. I can fill it all out for you, you know. I want to thank you all, and I want to thank everybody at the NYOH Foundation. Rachel, are you in the room? I don't see you. There you are. Stand up. The faculty will stay a few minutes. There is a book signing. If you'd like a book signing from Dr. Rourke, there's a URL code for Dr. Troso's book. I'm going to go home. I'm exhausted. Thank you all.